Thank you very much. It's fortuitous that I followed on from the last talk because lens removal has been my primary method of management of PAC and PACG since 1997. As the last speaker said, this has been validated by the recently published EAGLE study. And what it is, this is a preventative and at most part curative form of intervention. And the cost effectiveness we know, but it's also extremely clinically effective. EAGLE study again, as the last speaker mentioned, it showed greater efficacy and was more cost effective than laser PI. Now, looking at the epidemiology, I did think 20 years ago that it was mainly an East Asian disease, but since then it's been shown that it's actually very common in South Asia. And with Myanmar having the highest reported rates to date. Now, what PACG is, it really is a biomechanical condition. Pupil block, bladder virus, lens-induced, whatever mechanism you want to say, the cause of all of it really is a crowded anterior chamber. And removal of the lens resolves the overcrowding, so you create space. This is from this article, which is actually a very good article if you want to read through that one. Ultimately, everything is caused by crowding. Now we can see lens growth. Lens growth really takes off between 20 and 50 and keeps on increasing. So ultimately, it's the lens which, whatever mechanism you have, that is the one, the growth that actually triggers the thing off. It's not the other way around. It's actually the lens growth which is the most important thing. Now, the current dilemma is this. What we do have a very safe and effective solution for angle closure disease, but we're not really sure which people that we actually use it on. I mean, who would actually progress? Sorry, who would actually benefit from this particular condition? So we need to identify better who we can benefit. Now, current identification is mainly case-specific with patients either presenting with pathology or in a part of an eye exam. But with a 2% prevalence, you'd really want to consider screening, especially in high-risk populations, because a 2% risk of a catastrophic condition is not minimal. You know, I mean, I definitely wouldn't fly in an airplane if there was a 2% risk of a crash, and I wouldn't want a 2% risk of going blind either. Now, what is the risk of progression? This really is the crux of the issue. This is very, very important. There's actually not a lot of information on this important subject. And I'd really like to see a follow-up of the West Bengal study cohort. Now, one that has been done, this is from South India, from Vellore, and it shows that in that particular population, there's a 20% risk of progression from PACS to PAC. Now, that's actually a considerable risk. It's almost 4.5%, and may actually even be higher than the Greenland one. Now, the other thing that we really need to work on is defining what exactly is an occludable angle. Again, I know Paul Foster from 20 years ago. He was in Singapore. So he's done a lot of extremely good work. I mean, really, I only appreciate this now. So defining occludable angles again, and taking peripheral anterior synechia into account, which most of the normal grading schemes which are in use right now, they don't really take PAS into account, but you really need to take PAS into account. At the moment, it's a consensus definition of an angle at risk, which is 180 degrees of posterior trabecular wedge stroke not visible. This has not been validated, or there's actually, again, no mention of PAS, which is the primary pathology in angle closure glaucoma, chronic angle closure. Now, gonioscopy is invaluable, but again, it's very subjective. I'm not even sure that I see the angle the same way if I see the patient the next day. You know, I can't be completely sure. Question of inter and intra-observer reliability, and I suspect the view also varies with the type of lens used. But, you know, I have 2 or 3 different lenses and I look through them and the angle seems to look different with some of them. So, again, I really think we're getting to that phase now where we're going to be screening a lot more. I don't have a lot of time, so I'm going to rush through this. So technology is moving at a rapid pace, and within 5-10 years, I think we'll be screening for a lot of these things. Now, what about OCT? Again, the pictures look pretty, but poor specificity when using gonioscopy as a reference, and surprisingly, poor inter-assessor agreements, especially for SD-OCT, which is around 55. Now, that's really not very good. This is a swept source OCT, and you can see that it actually gives quite a lot of detailed information. But again, you have to wonder, is that information really something that you're seeing, or it's not? So you need to compare a lot of these with gonioscopy. OCT is very good for a horizontal shot. As you can see here, this is one of my patients with an obviously closed angle, which I could see on a gonioscope. But I tried to take a superior hemisphere scan. Now, forget even about the lid. Forget about the lid. You just look at the 12 o'clock. Again, you know, the image reconstruction is very, very poor. So this needs a bit of a way to go. Again, now one thing that I keep coming back to as something that can be used, you know, which is not expensive, which is really the Van Herrick test, you know. I mean, I know that some of the epidemiological studies have done work with the Van Herrick test, but it doesn't show very good sensitivity or specificity, but it's extremely easy to use, and I think I wonder if there's some way that it can be made more effective. Now, I think there was a scheme proposed here to actually do that, but again, when I looked at it, it's not that easy to use. You know, you have to tell the difference between a 5 degree and a 10 degree and a 20 degree. You know, one day it might look a 5 degree, another day it might look a 10 degree. You know, it's just cumbersome to use. Now, let's go to the ICO guidelines. Again, I would, you know, these are, I'm not sure it's visible very well, but you can get you probably get the guidelines at the booth. They have recognized the role of lens extraction. This was from 2016 for most things. Now, the tools are there. We have the tool to actually cure angle closure disease. Now, what we require for this one really is open mind and hard data. You can't accept paradigms from different areas. You know, it's not. You have to consider the local environment and logistical issues. So I think a lot of extremely good work can be done in India. This is my personal algorithm. It can change at any time. One thing which is different is that I would never do a drainage procedure in an angle closure without lens removal. It just doesn't make any sense to me. Thank you.